All right, no disclosures. Question, what is malnutrition?
That's a multifaceted question.
Very good, yes.
That depends on where you're at as well in the world. Like, unfortunately, here in the United States, we see malnutrition coming in. We're like we have a lot of food, but it's not very nutritious, right? And then we have other people in other countries who literally don't have any food, and we're trying to find ways just to make sure that they get the essential things that they can do to function.
Awesome. So here's like a general World Health Organization definition. So we've got the deficiencies, excesses, or imbalances in a person's intake of energy or nutrients. Does that seem like a reasonable, broad definition? There's a lot of general ones, but that's kind of the main point. Okay, so I want you to think for a minute about the types of malnutrition that you see here in the United States. And like Natalie mentioned, we have a lot of imbalances, a lot of obesity, a lot of highly nutrient poor but calorie dense foods. We also have a lot on the flip side, probably more than you might imagine. So the 2024 USDA Food Security Report tells us, and see, I won't remember numbers, so I have to read them. 47.4 million people live in food insecure houses in the United States, and that's 13.5% of all households in the United States are dealing with food insecurity. This is up from 12.8% in 2022. I'm sure it's higher this year. This impacts 13.8 million children in the United States. We're not talking worldwide. CDC, malnutrition deaths more than doubled from 9,300 in 2018 to 20,500 in 2022, with older adults and people who have disabilities being particularly vulnerable. Part of that is due to COVID epidemic, and part of that is due to shifting availability. And here's some interesting ones. Utah, New Mexico, and South Carolina have the highest death rates of malnutrition in the country. So it's around you. You may not see it, but it's here. And I would absolutely love to be dead wrong, but it's going to get worse, especially with social, political, climate change. So you're going to see patients with malnutrition more than you are now, and you may be seeing more people dealing with malnutrition than you realize. So, does malnutrition play a role in spine and orthopedics? Lots of nods, yes, good. Good answer. So here are some of the complications and things that we see. So you have, this is kind of in the little bit more focused to the surgical world, wound healing complications, infection, increased length of hospital stay, renal complications, mortality, increased non-union rates. There are impacts in disability scores that are kind of interesting. ODI is associated with iron deficiency, and both ODI and physical health are associated with B vitamin deficits. So you are seeing these changes that may be due to some degree of malnutrition, and it just kind of depends on what's going on the individual. A little bit more to the therapy world, lower grip strength, gait speed, timed up and go, short physical performance battery points, quality of life. Obviously we have an increase in sarcopenia, and this includes sarcopenic obesity, and then we get changes in the nervous and skeletal systems. So tell me what you envision when you think of someone with malnutrition. What comes to mind?
Ethiopia.
Mm-hmm. Is that kind of the general picture everybody gets when you think malnutrition?
I maybe have a different aspect to that. I see a lot of elderly people, senior population. I just had a patient like a surgeon 2 weeks ago who was a vet. He's served in the military, and he's malnourished. That was like his primary diagnosis. This week, really skinny, really weak, but not in Ethiopia. Right here.
Great.
I was going to say, mostly geriatric providers, so seeing these patients that come in to where I help and treat them, it's, you know, the frailness that goes along with the inability to participate in activities of daily living. Like some of the things that you mentioned, you know, they're oftentimes you can physically see the skinniness. I'm always like, you need to get some meat on your bones. Like, what can we do to help you, you know, with the extra protein and nutrition and vitamins and things like that they just aren't getting. And I think it's interesting when you're mentioning the numbers. It's amazing. I always am thinking in my mind when I get a brand new 98-year-old patient that is malnutrition, and I'm like, man, they've been living like this in the community with no one knowing for years until they fall. And then now they come into the health community and we see them. But they're a dime a dozen. You know, I have 12 patients that are malnutritioned right now. And no one knew they were malnutrition until they fell or something happened, and now they're into the healthcare system and we see it.
Yeah.
So it's there. It's just sometimes we bypass it because right now someone else is taking care of them or they're in their home. We're not seeing that in the community until something happens.
Exactly. Thank you. Brian?
Jennifer, and just really close to home, we have at least a couple of latchkey kids in our neighborhood. Now we know that they either have a single parent or both parents are working extensively outside the home. It's not just our neighborhood kids, but it's sometimes pediatric patients you notice coming with different caregivers. You know that they're just not getting continuity. You know that they're just coming home and they have got these processed snacks just ready to open and eat. They're just nutrient poor but calorie dense. So being able to identify these kids and hopefully able to help in some way.
Yeah, thank you.
To that point, and others, that the imbalance of nutrition seems to be part of it as well. Particularly some of the older patients that are obese but have on their imaging or on physical exam very little muscle, and their bones are not very strong, and it becomes a really challenging situation because they're at risk of many musculoskeletal issues, and then their tolerance to treatment is poor. So there's sort of, it seems like there's a subset of patients that are not getting the adequate micronutrients that are needed to support their tissues.
Yeah, thank you. Okay, so next question is how you identify someone with malnutrition.
You had us implement the grip strength test in clinic a while ago, and that's been a really helpful tool. In fact, I even referenced the grip strength on one of the patients I was reviewing this morning, and it was immediately apparent that this patient was weak, and the grip was way lower than expected. So that's so easy to do, and it's patients, I think, kind of like to have a number, and we like to have a number just to give us a general strength and then symmetry to know if, gosh, this hand's a lot weaker than the other. So it's helpful for lots of things.
It is. Besides, it entertains the PCCs who have a running competition of who's the strongest, right? Perfect. Okay, we actually have several things that we can consider. So one of the ones that's used most often and may be helpful, and sometimes it is and sometimes it is, well, a lot of times it's not giving you the full picture of who is dealing with malnutrition, would be a low BMI. So someone with a BMI under 18.5 is of concern. You also have weight loss. So someone who is not deliberately trying to lose weight, but losing weight over time, and also losing both just overall weight, but also free fat mass. There are some lovely ICD-10 codes that we can use, And these are important because these are key indicators to say, hey, this person has a problem and this needs to get into their medical record. So you've got 3 different general categories of malnutrition: the severe protein calorie malnutrition, malnutrition that they call of a moderate degree, and then mild. That whole moderate and mild thing is very subjective and kind of depends on who's assessing and what things they're looking at. But if you look at some of those things to consider, it's like, okay, great, this is helpful, but is this consistent? So there's it's called the subjective global assessment that gives some general ideas for looking at malnutrition criteria. This kind of compares it with the Academy of Nutrition and Dietetics and the American Society for Parenteral and Enteral Nutrition. And a lot of these are the same, and some of them are a little different. So you can kind of see even the guidelines that are these great organizations are a little bit different. So some of this is because people are different, right? And the ways they show up with malnutrition are going to be a little bit different. But this gives a good kind of general overview. But one aspect that covers several of these components is called the nutrition-focused physical exam. And if you look at this, it's kind of giving you some general sites in the body where it's easy to see where there are indicators that someone might have a problem with malnutrition. This includes mostly, a lot of this is, muscle fat, but then you can also see some micronutrient deficiencies, which I know you totally can't see to read this. It's to show that there are a lot of nutrients and a lot of abnormal findings that we can look at and see those micronutrient deficiencies. So just pulling one out. So take a look at this skin. Does that look normal? But it doesn't look like totally crazy weird, right? But those are all potential indicators for vitamin C deficiency. The corkscrew hair, the petechiae, little bits of keratosis can all indicate potential vitamin C deficiency. So I want to go through a case, and I used to share this with my biochemistry students. Got David Jones. He's an entrepreneur in acquisitions. He has lacked fresh fruit and vegetables due to his work conditions for the last 3 months. And he's developed the following symptoms: fatigue and malaise, clogged, enlarged, hyperkeratotic hair follicles with petechiae. See, I just gave away the answer. Easy bruising and splinter hemorrhages, swollen, bleeding, necrotic gums, sublingual hemorrhages, loose and decaying teeth, easily fractured bones and bone pain, changes in personality and behavior. So all of those symptoms can be associated with a vitamin C deficiency, which we also refer to as scurvy, which you think about as being gone, right? Oh, scurvy is an old thing that they used to have back in the 1800s. Sailors died from. Yeah, people get scurvy today. And it's mostly in areas where there are food deserts, that there's just not a lot of access to fresh fruits and vegetables. You guys know who this is, right? Davy Jones? Yeah, okay. Sometimes the students get it and sometimes they don't. The locker part? Yeah. Okay, so what does a nutrition-focused physical exam look like? It's a head-to-toe assessment, and basically we're looking at fat and muscle wasting. We're looking at hair, eyes, skin, nails, face, tongue, all of those different areas, all the way down to the feet, looking for edema and identifying where we might see wasting or some of those physical signs of micronutrient deficiencies. So we are going to do, forgot. Dr. Edwards already brought up hand grip strength. This one's like fun and easy, and everybody likes to just see what their hand grip strength is. And it gives you lots of great information. If they've got reduced strength of like 2 standard deviations below what you would anticipate, that's a good indicator that you should do some further looking to see if there's some malnutrition. And it's one of the first things to show up, that you'll see that loss in grip strength before you start seeing some of the other indicators of wasting. But the question is, how do you know if it's malnutrition or if it's something else? Like if there's muscle wasting because of a nerve impingement and they need surgery, right? Question, right? We don't know the answer. This is why we have to look at everything and look at the whole big picture and see what else is going on and ask questions. All right. Now we're going to go. We are going to do a mini assessment. I call it mini assessment because I'm only going to have you do faces and hands instead of everywhere else for obvious reasons. So find a partner. Everybody got a partner? If you need to find a trio, find a trio. Okay, so what I want you to do is look at your partner, and we're going to start just visually. So we're going to look at the temporalis muscles, right? And those who have glasses will have to take them off after. Okay, you can kind of see in this picture the difference. So you've got a little bit of sinking there. Okay. The other ones we're looking at are the fat pads, the orbital fat pads around the eyes. And then the buccal fat pads in your cheeks. This one's interesting. We've got great pictures now because there's this fashion trend of having your buccal fat pads removed. And so you can see that big sunken area there. This is going to look really interestingly weird when some of these people are 20, 30 years older than they are now that are having that done. But it makes for nice pictures to be able to see that obvious difference in having or not having those fat pads. I am not going to make you look for all the micronutrient deficiencies because it's hard and we're just have a little bit of time. But you can also see multiple micronutrient deficiencies by just looking in someone's eyes. Potentially. There might be other things going on if they're on medications or have other conditions, but it's something to look at. So go through and look. And we'll start with the orbital fat pads. And you can do some palpation. Stop you for a second. Okay. Can you feel as you're touching someone's around their eyes? Hopefully everyone here is malnourished, but there may be some people with some sunken eyes because they're exhausted. Okay, the temporalis muscle. And there are some of the different levels there. So if you can, the temporalis is usually harder to see and easier to feel. So feel along your partner's face and see if you can feel that. And those buccal fat pads are a little bit easier to see than feel, but if you feel it, you can also tell if there's some sinking. Okay, anybody find any problems? The hope is not. All right. We're going to look at hands. So for some people that are older, you're going to see this very, very obviously, right? You can see the deep loss of muscle, even just if their hand is sitting there. It's also a good way to look is to have them touch finger to thumb and feel in between in that thinner and area, and you can feel that, oh wait, there's muscle missing, or that it's there. But when you're looking at hands, you can see that depression, or else you can feel, especially around the thumb. All right. Hopefully everybody's had a chance to try things out. So tell me what your thoughts are.
I think just it's a good to be aware of things to look for, and as you're talking about it, you start realizing things that we have seen that we probably didn't correlate with a malnourished state, and now probably would be more likely to say, oh yeah, that's probably what that's from. Just paying attention.
Yeah. Can you envision in your mind people that you've seen lately that you're like, oh, yeah, that's what their face kind of looked like?
So we're talking more about the elderly population, but aren't we seeing a lot of people on GLP-1 agonists that might fit this category?
Yes. Depending on how their weight loss is going, yes, you can lose a substantial amount of muscle along with some of the fat.
I've seen it a lot in patients.
And so yes, you are going to see some of those changes that are happening. Yeah. Other thoughts?
I know what I'm new about. It seems like I can look at Steve today. So pretty. But and obviously he's I know him, right? And so I could probably recognize if he wasn't feeling well in month because I could tell the difference. And I think that on a case-by-case basis that there make a big difference. And I think it's a good testimonial for at-risk populations like the elderly to have a continual education with their healthcare providers, so that it's a change that we're going to notice more than when they sit down one time, right?
Right. Yes. So paying attention over time, definitely.
Question. Most people do physical tests. We do blood work every year. Does this show up? Can it show up on some blood work? I know vitamin D is not a normal blood test, but
some things can. So actually, the blood tests are not the greatest for showing malnutrition unless you've got a micronutrient deficiency, and even then, odds are it's not going to show up. For example, calcium. Our bodies are amazing at regulating calcium levels. So you have to be in a really bad critical care situation before that calcium level is going to change. But you can have somebody who's losing calcium from their bones all the time, right? So iron is one of the exceptions that iron status will change, and you'll see that in the blood tests. But most of the other, albumin is honestly not a really great indicator of nutritional status. You can have someone whose blood levels look okay, and they are not okay. So all of the other pieces are actually important. So I'm kind of going to flip to this, because you guys are not all responsible for diagnosing malnutrition, right? This is something that you need to recognize, ask questions, see the risks, do some screening, and then make the dietitian do all of the full assessment, which is not just this physical exam, it's a whole battery of other things. You've got anthropometric, some of the biochemical that shows up, these clinical evaluations, doing a diet history, talking to the person about what is typically happening, talking to them long enough that they will tell you the truth about what's going on, because people don't. Because it's hard to admit sometimes that, no, I don't have enough food, I'm not okay. Or, no, I'm eating the wrong kinds of things, and it's challenging, so it takes some time. And then looping back around to the circle to have the discussion about that diagnosis, because unfortunately, I can't, enter a diagnostic code into the person's chart of malnutrition. I can diagnose them, but I can't finish that circle. So communication is important.
So I'm just, as I think about the world in which we live, and then there's a reason that maybe seniors tend to be a little bit more susceptible to this, and it's because inexpensive food is not usually the best food for us. So we package and processed food, and we make it easy. You can drive through and get it for, I don't know, I don't even know the price is, $3.99 or $1.99 or something like that. But it's caloric dense, nutritionally desert, yet that fits within their budget. And I don't even know what the resources are to be able to help them. I mean, I know there's senior centers and Meals for Wheels and things like that, but I think being able to plug our patients into resources as I think about it, I'm like, well, what's my next step? Besides telling them, and I'll tell you a story about another patient later, it's not relevant right now, but what's our next step for being able to intervene? Like, look, you need to eat more broccoli, or whatever that is. And they just go, okay, fine, thanks. I'm having enough trouble paying for this appointment as it is.
Right.
How do I go back and do something else?
And part of that is, yes, connecting with resources, and I should send out, there are some community resources available to help connect people to food. There are some really great programs that if you happen to be connected with someone in the restaurant business, that up in Salt Lake, they've gotten a system that's really good with connecting people who are in the restaurant business, getting their leftovers packaged immediately and delivered out, mostly to students at the University of Utah as one of the groups, and then to some of the shelters up there in the Salt Lake area. So there are things that are working well, and there are things that we need to do better in the community to get food to people. Policy is going to be challenging, especially. There are opportunities with schools that are helpful. It doesn't help the elderly as much. And then some of the other things are helping people to see that it doesn't have to be as hard as they think it is to prepare healthy food. So one of the things is people are like, well, I just can't get fresh fruits and vegetables. Great. Frozen are just as healthy, and you can just have it there in the freezer and pull it out and microwave it. It can be easier than people are thinking that it has to be, because sometimes it's hard to connect that, oh, it really is that easy. I can really actually do this. So giving people the education and the resources and examples of super easy, healthy meals. You can dump a can of tuna onto a plate, sprinkle some dill on it, warm it up, and add some frozen vegetables, and there are things that take 2 minutes, right? But they don't think about it because they think, oh, well, it has to be, I'm turning my tuna into a casserole or something, and I don't feel good enough or have the energy to do all of that. So it's challenging, but people can do it, and we just need to build that community trust and share the information and the education. So, comments? All right, thanks.